My dear listeners, and welcome to part 30 of our Pharmacotherapy MCQs series. My name is Nath Arwa and I'm the founder of Progressive Pharmacotherapy Consultants. I am a clinical pharmacist by training and by profession. Welcome to the premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment or clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to humbly urge you to sit back and spare me part of your very precious time as I share a few tips that will enhance your effectiveness as you deliver services. So welcome. So our first question reads, KHR, a 68-year-old man, presents to the clinic with an altered mental status. His heart rate is 26 beats per minute. He has a systolic blood pressure of 188 and a diastolic blood pressure of 106. His respiratory rate is 16 and his oxygen saturation is not bad. It's 99% on room air. The team administers 0.5 milligrams of IV atropine twice and there is no response yet. The patient is awake. Another attempt of pharmacologic pacing is requested by the clinical team before transcutaneous pacing. So my question to you is, which of the options below would be the best one for this patient KHR? Would it be administering dopamine at a dose of 2 micrograms per kilo per minute, or would it be the administration of 5 micrograms of epinephrine per minute, or would you opt to administer 100 mics of phenylephrine per minute, or would you instead administer 2 mics of isoproterenol per minute? I'll give you 10 seconds to choose the correct answer. In my opinion, D is the correct answer. I would administer or recommend the administration of 2 mics of isoproterenol per minute. Now, isoproterenol is a unique agent that stimulates both beta-1 and beta-2 receptors. The hemodynamic result is increased inotropy, chronotropy, and vasodilation. Now, in rare circumstances where a patient is symptomatic or symptomatically bradycardic but hypertensive, it is a very reasonable option. On the other hand, epinephrine, dopamine, and phenylephrine will all further increase the blood pressure and they would worsen the situation. They aren't ideal in this scenario we are faced with. Dobutamine is the closest agent to isoproterenol based on mechanism of action, as both of them affect beta-1 and beta-2 receptors. Now, the pharmacologic effects of dopamine are dose dependent. Just to remind you that for doses below 5 mics per kilo per minute, the dopamine agonist effects predominate. Now, from 10 mics per kilo per minute, the beta-1 agonist effects dominate, and from 15 onwards, it's considered a vasopressor. Doses from 15 mics per kilo per minute onwards are considered vasopressor dosing used in patients in shock. Just to remind you, And phenylephrine is a pure alpha-1 agonist at normal therapeutic doses, and it's used to cause or to exert vasoconstriction. Let's move to the next question. It reads, which of the drugs listed below is the most commonly recommended for use as a once monthly therapy for patients with homozygous familial hypercholesterolemia? Is it lomitapide? Is it alirocumab? Is it evolocumab? Or is it Mipomersen? I'll give you 10 seconds to choose the correct answer. Is the correct answer in my opinion. Evolocumab, which is also known as Repatha, is a PCSK9 inhibitor antibody which is administered monthly subcutaneously as an adjunct to diet and other LDL lowering therapies in what we call the HoFH patients who require additional lowering of low LDL cholesterol. Now, alirocumab, which is marketed as Praluent, is also a PCSK inhibitor antibody, and it's administered bi-weekly, every 2 weeks subcutaneously in many cases. However, it does have a dosing recommendation for later use to be given as 300 milligrams once a month. Now, lomitapide, which is also marketed as Juxtapid, is a microsomal triglyceride transfer protein inhibitor that is administered orally once daily. And then Mipomersen, which is marketed as Kainamro, is an oligonucleotide inhibitor of apolipoprotein B100 synthesis, and it's administered subcutaneously once a week. It's a weekly regimen. So all those many words explain why C, evolocumab or Repatha, is the best option in this particular case. Let's move to the next slide, please. ASL is a 35-year-old patient who presents to the clinic. Now, ASL has a past medical history of type 2 diabetes mellitus, and he is given a diagnosis of hypertension after you do a physical exam. My question to you is, which of the scenarios below would make lisinopril use contraindicated in the hypertension management in the case of ASL? Would it be bilateral renal artery stenosis? Would it be a sulfur allergy? Would it be microalbuminuria? Or would it be moderate to severe asthma? I'll give you 10 seconds to choose the correct answer. A, it is bilateral renal artery stenosis. So contraindications to the use of ACE inhibitors, like the drug we are discussing now, include a known allergy to the ACE inhibitors, which can include conditions such as angioedema. Another one would be hyperkalemia, or when the baseline potassium was above 5 prior to initiation of therapy. And then a third one would be bilateral renal artery stenosis. Now, hypotension or unstable hemodynamics are also contraindications for the use of ACE inhibitors. Now, ramipril doesn't have a sulfonamide moiety and isn't contraindicated in patients with a reported sulfur allergy. That makes answer B wrong. Then I would also like to say that ACE inhibitors are or can be helpful for patients with microalbuminuria, especially if they have underlying diabetes mellitus. That makes answer C wrong as well. Then while lisinopril can cause a dry non-productive cough, the use of ACE inhibitors in asthmatic patients isn't a contraindication. So I would just like to emphasize that when you put patients on these ACE inhibitors, because they tend to cause hyperkalemia, counsel patients to avoid salt substitutes, since salt substitutes have sodium replaced with potassium, which can further increase the risk of hyperkalemia. Now, for patients with stented open bilateral renal artery stenosis, we can still exceptionally prescribe and administer ACE inhibitors. So let's move to the next question, please. It reads, which of the medical conditions listed below is one of the three most common uses of common causes of heart failure with a reduced ejection fraction, what we call HFrEF, in adult patients? Is it polycystic kidney disease? Is it uncontrolled hypertension? Is it moderate to severe COPD, or is it pericarditis? I'll give you 10 seconds to choose the correct answer. So B it is, uncontrolled hypertension. Now, the three most common causes of HFrEF in the US and in many other countries include uncontrolled hypertension, valvular disease, and coronary artery disease, which can also be caused by ischemic heart disease. Now, a reduced ejection fraction is usually considered to be a value less than 40% as determined by an echo. Now, patients with HFrEF experience symptoms such as shortness of breath, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and fatigue. I would also like to remind you that the underlying approach to the prevention of heart failure is prevention by treating the underlying etiology. While pericardial disease is a potential cause of heart failure, it isn't one of the three most common causes. So that makes answers A, C, and D incorrect. Let's move to the next slide, please. So the next question reads, which of the vasopressors listed below used in the management of hypotension rapidly stimulates only alpha-1 receptors in the vasculature and increases the afterload or systemic vascular resistance, what we abbreviate as SVR? Is it norepinephrine, epinephrine, phenylephrine, or vasopressin? I'll give you 10 seconds to choose the most appropriate answer. So phenylephrine it is. Now phenylephrine, which is also called synephrine, is a vasopressor with pure alpha-1 agonist activity and is primarily only used for rapidly increasing blood pressure when it's very low, when there is serious or severe hypotension in shock. Norepinephrine is generally considered to be a vasopressor that primarily stimulates alpha-1 receptors to increase the afterload or SVR due to its vasoconstrictive properties on the arterial vasculature. It can also stimulate beta-1 receptors, leading to a slight increase in the pulse rate, though this isn't the primary effect of norep. And then epinephrine is a vasoconstrictor that is thought to have equal activity with regard to alpha 1, beta 1, and beta 2 receptors. Vasopressin, on the other hand, which is also called vasostrict, is a vasopressor that is known to stimulate the V1 receptors, and it causes vasoconstriction and an increase in SVR. It is the one vasopressor that can be used via IV push. It can be IV push dosed, unlike the others, just for your information. So let's move to the next question, please. EAO, a 78-year-old male patient, presents to the clinic for his annual appointment. He has a past medical history of heart failure. He describes his activity level as sedentary. He informs you that walking 50 feet to the neighboring kiosk for shopping causes shortness of breath and occasional chest pain to him. So my question to you is, how would you classify Mr. EAO's heart failure? Does he belong to NYHA class 1? Does he belong to AHA stage B? Does he belong to NYHA class 2? Or does he belong to AHA stage A? I'll give you 10 seconds to settle for the best alternative. The best option is C. He belongs to class 2, NYHA class 2. Now the NYHA describes heart failure in a functional way and is subjective in its interpretation, in my opinion. Class 2 is described as a slight limitation of physical activity. Now such patients are comfortable at rest, but ordinary physical activity results in fatigue, palpitations, or dyspnea. Now the AHA staging system describes the stages in the development of heart failure, which includes a more objective assessment. That is to say, they involve things like the echo evaluation of the size, the ejection fraction, wall motion of the heart. And then patients diagnosed with heart failure are generally in stage C or D, just for your information. Let's move to the next slide, please. So which statement below is accurate about HMG coenzyme A reductase inhibitors used in the treatment of hyperlipidemia? Is it true that they are associated with very few drug-drug interactions? Or is it true that almost all the statins are highly dependent on renal clearance and require dose adjustment in mild chronic kidney disease? Or is it true that the risk of muscle damage or myositis is dose or concentration dependent? Or is it D, they work directly by preventing PCSK9, thereby preventing the downregulation of LDL receptors? I'll give you 10 seconds to choose the correct answer. In my opinion, C is the correct answer. The risk of muscle damage or myositis is dose and concentration dependent. Now, HMG coenzyme A reductase inhibitors cause dose dependent and concentration dependent increases in the risk of both muscle damage and inflammation, as well as liver damage and liver inflammation. Now, at normal doses without non-drug-drug interactions playing a role, the risk for both is low. Now, while some statins have recommendations for renal dose adjustments, it is usually only a consideration in patients with severe renal impairment. In general, they are fairly safe. Now, statins don't have a significant dependence on renal elimination. That's a fact. HMG-CoA reductase is an enzyme involved in the hepatic production of cholesterol, not directly inhibiting the PCSK9. PCSK9 inhibitors such as evolocumab and alirocumab are known to prevent the downregulation of the LDL receptor, thereby allowing them to remain available to extract LDL cholesterol out of the bloodstream. So that does not apply to the statins. And just like to emphasize that some statins have been associated with clinically relevant drug-drug interactions, especially those that have more dependence on the CYP3A4 enzyme system, such as atorvastatin, lovastatin, and simvastatin. So be aware when you have drugs co-prescribed with them that are also metabolized via the same CYP enzyme system. Just as a by the way. Let's move to the next question, please. SJS, a 59-year-old female, presents to the accident and emergency with a chief complaint of increased swelling of her ankles, which began after the recent modification or change of her antihypertensive medication regimen. Unfortunately, she doesn't recall the changes that were made. She doesn't remember which drug could be the culprit. So she leaves you guessing. Now, her current meds include losartan, metoprolol, amlodipine, and clothalidone. So my question to you is, which of the drugs listed below is most likely to be the cause of SJS's complaint? Could it be clothalidone, amlodipine, metoprolol, or losartan behind the swelling of her ankles? I'll give you 10 seconds to choose the most appropriate response. So amlodipine it is. Now amlodipine is a non-dihydropyridine calcium channel blocker, and it will be the likely cause of her lower extremity edema due to its vasodilatory effect and an increase in hydrostatic pressure that results in the capillary leaking in dependent tissues. Now, alternative D, losartan is an ARB, and alternative A, clothalidone is a diuretic. Now, both of them would reduce plasma volume with a decreased risk of extremity edema, so they are not the cause of her problem. Then metoprolol is a beta-1 selective blocker, which can also antagonize beta-2 receptors in the vasculature. Now, antagonism of these beta-2 receptors in the blood vessels results in constriction and not dilation, so it would not be a cause of the swelling. Now, beta blockers also inhibit beta-1 mediated renin release from the JG cells in the nephron, and this would presumably reduce the plasma volume, and the risk of a lower extremity edema is very narrow, almost close to impossible with the use of metoprolol. So the correct answer there, in my opinion, is amlodipine. Let's move to the next slide, please. So XPD, a 74-year-old male, presents with the accidental emergency with the supraventricular tachycardia. He has a past medical history of atrial fibrillation, hypertension, and heart failure. He currently takes metoprolol tartrate at a dose of 100 milligrams twice daily, 0.25 milligrams of digoxin once daily, and 5 milligrams of warfarin. So because of his arrhythmia, adenosine is administered. So after adenosine administration, XPD's underlying arrhythmia is identified as AFib with rapid ventricular response, but his ventricular rate is back to 160 beats per minute, pretty high. Now the clinical team intends to load him with amiodarone at a dose of 150 milligrams IV over 10 minutes, now, as soon as possible. So my question to you is, which of the modifications below would be appropriate for this particular patient XPD? Would we need to decrease the digoxin dose to 0.125 milligrams per day? Or would we need to decrease the metoprolol dose to 5 milligrams twice daily orally? Or would we need to decrease the warfarin dose to warfarin dose to 10 milligrams once daily? Or would we have to decrease the amiodarone dose to 75 milligrams IV over 10 minutes? I'll give you 10 seconds to choose the correct answer. In my opinion, the best bet would be to decrease the digoxin dose to half it to 0.125 milligrams orally once a day. Now, patients that are taking digoxin and are subsequently initiated on amiodarone should have their digoxin doses empirically reduced by up to 50%, and I'll tell you why. This is as a result of the P-glycoprotein inhibition by amiodarone, which leads to an increase in the digoxin bioavailability. So if you don't adjust the dose, toxicity will ensue. Now, decreases in metoprolol may be reasonable, but a decrease from 200 milligrams in a day to 10 milligrams in a day isn't appropriate. Then amiodarone increases the therapeutic effect of warfarin due to amiodarone's inhibition of the CYP2C9 and 3A4 dependent metabolic pathways of warfarin, and therefore the doses should be decreased. Now, an amiodarone dose of 75, as written in option D, is not appropriate for adults. We don't go that low in adult patients. Amiodarone, just for your information, is classified as a Vaughan-Williams class 3 antiarrhythmic drug, but it demonstrates characteristics of all the 4 classes. And there is no need to worry when the patient tells you they are allergic to iodine if you are administering amiodarone, because iodine isn't an allergen. Now, just as a by the way, dronedarone is a deiodinated analog of amiodarone, and it's only available as an oral dosage form, unlike amiodarone, which is IV stroke oral. Now, the dronedarone has a narrower spectrum of indications, and it is contraindicated in patients with symptomatic heart failure with recent decompensation requiring hospitalization, and in patients with permanent atrial fibrillations, since it doubles the risk of death, of stroke, and hospitalization for heart failure, just for your information. Let's move to the next slide, please. PAO, a 66-year-old female, presents to the hospital for routine follow-up. She has a past medical history of hypertension, coronary artery disease, hyperlipidemia, and type 2 diabetes mellitus. Some of her vitals when she presents to the hospital include systolic blood pressure of 156, diastolic 88, with a heart rate of 65. Now, the values of her home reading are at an average of 151 systolic, 81 diastolic, with a heart rate of 61 respectively. And after carrying out laboratory investigations, you establish that the values are within normal limits. The patient says she is fully compliant with her medications and follows what we call a heart-healthy lifestyle. She is currently taking 40 milligrams of lisinopril at night, 25 milligrams of carvedilol twice daily, 50 milligrams of chlorthalidone once a day, 10 milligrams of amlodipine at night. So my question to you is, what would be the best approach of managing PAO's hypertension? Would you introduce or initiate 25 milligrams of losartan once daily in addition to her current regimen? Or would you opt to continue with status quo and maintain the same regimen at the same doses? Or would you initiate spironolactone at a dose of 12.5 milligrams orally after breakfast? Or would you introduce furosemide at a dose of 40 milligrams after her breakfast? I'll give you 10 seconds to choose the correct answer. So I would opt to initiate 12.5 milligrams of spironolactone after her breakfast in addition to her current regimen. Now, considerable evidence indicates that the addition of spironolactone to multi-drug regimens provides substantial blood pressure reduction for treatment of resistant hypertension like we have in this case. Now, this patient isn't at goal according to the ACC/AHA guidelines, which demands values of 130 systolic, 80 diastolic. Neither is it at goal according to the J&C8 guidelines, which demands 140 systolic, 80 diastolic. And in my opinion, additional blood pressure lowering would be appropriate to reach those goals. So that makes answer B wrong. We can't maintain status quo. We have to do something. Now, S inhibitors co-administered with an ARB isn't appropriate for the treatment of hypertension due to increased risk of side effects such as hyperkalemia. Remember, both ACE inhibitors and ARBs can cause hyperkalemia and they can cause acute kidney damage, and that makes answer A wrong. I would not advise reintroducing losartan 25 milligrams orally once a day. It would pose more threats to the patient's condition. Now, the patient is already on a thiazide-like diuretic, chlorthalidone, if I remember, no, furosemide, sorry, if I remember well. No, it's chlorthalidone. If I remember well, I think the patient, is taking 50 milligrams of chlorthalidone daily. So because he's already on a thiazide-like diuretic, there isn't enough supportive evidence to support adding a loop diuretic like furosemide in his case. Now, dual diuretic therapy is reserved as a last-line treatment for volume overload in congestive heart failure. We are not yet there in this patient's case. Our problem is resistant hypertension, not congestive heart failure. So I would not favor furosemide. Then the diagnosis, I would just like to emphasize that the diagnosis of resistant hypertension is made when a patient takes 3 antihypertensive medications with complementary mechanisms of action but doesn't achieve goal BP, or when the blood pressure goal is achieved but requires 4 or more medications. So our patient here qualifies to be classified as having resistant hypertension. Now, spironolactone is an aldosterone antagonist which is effective in treatment of resistant hypertension. There is also clinical evidence that addition of hydralazine or minoxidil can be effective in achieving BP control, just like the addition of spironolactone in patients with resistant hypertension. So if you had no spironolactone to fall back to, then hydralazine or minoxidil would be alternatives. Just as a by the way, let's move to the next slide, please. So the question reads, which of the drugs listed below binds to alpha-2 receptors and results in an overall decrease in sympathetic nervous system output from the CNS? Is it doxazosin? Is it prazosin? Is it nicardipine? Or is it clonidine? I'll give you 10 seconds to choose the correct answer. So catapres or clonidine it is. Now clonidine is the only alpha-2 receptor blocker in the list above. Now once it binds to the presynaptic alpha-2 receptors, the net effect is usually a reduction in the release of the neurotransmitter, which is in this case norepinephrine, and that results in a reduction in sympathetic outflow from the central nervous system onto various organ systems in the body. Now nicardipine there is a dihydropyridine calcium channel blocker, so it doesn't meet those conditions. And then doxazosin and prazosin are both alpha-1 receptor blockers, and they work primarily on the peripheral vasculature. They don't meet this description either. So let's move to the next slide, please. JMC, a 59-year-old male patient who has been in atrial fibrillation for the past 10 days, presents to the hospital. Now, JMC has a past medical history of hypertension and type 2 diabetes mellitus, and he informs you this is the first episode of atrial fibrillation. Now, an echo was done a month ago, and it showed a normal ejection fraction of 60%, and there was no evidence of left ventricular hypertrophy. Neither was there evidence of ventricular dysfunction. Now, today's chief complaint is occasional palpitations that occur mostly when he exerts himself, when he's active. And his current heart rate is 120 beats per minute with a blood pressure of 140 systolic, 85 diastolic. He's currently taking 10 milligrams of lisinopril to manage the hypertension once a day, alongside 5 milligrams of glipizide taken orally once a day to manage the type 2 diabetes mellitus. So my question to you is, which of the classifications below best describes JMC's atrial fibrillation as we speak in this particular clinic visit? Is it paroxysmal atrial fibrillation, or is it recurrent atrial fibrillation, or is it persistent atrial fibrillation, or is it permanent AFib? I'll give you 10 seconds to choose the correct answer. So in my opinion, this is a persistent atrial fibrillation. Now, paroxysmal AFib lasts 7 days or less. Persistent AFib lasts longer than 7 days and can easily be cardioverted. It is important to consider the timing of the onset of AFib, since it can influence your approach to treatment. Now, if a patient is in permanent AFib, the additional risk stratification should be done using tools such as the CHADS-2 score to determine the risk of cardioembolic stroke and the need for possible long-term anticoagulation, so that your patient gets good value for money. Just as a by the way, let's move to the next question, please. AHJ, a 50-year-old man, presents to the hospital. He had suspected STEMI 1 year ago, but that was not treated. Today he has a chief complaint of dyspnea on exertion. Now his lab results don't suggest the presence of an MI. His ECG shows pathologic Q waves in leads V4, V5, V6 and AVL that are similar to the previous ECG that was done 90 days ago. He experiences shortness of breath and fatigue quickly with the activities around the house, minor light chores, which require little effort. Now, currently, he is unemployed and isn't active because of the dyspnea and the fatigue. A transthoracic echocardiogram reveals an ejection fraction of 30% and a left ventricular hypertrophy. He has only trace peripheral edema on physical examination. So my question to you is, which approach below would be the most appropriate for AHJ's medical management, or whichever intervention you opt to use? Would you opt to initiate a low-dose S inhibitor or an ARB? Or should he have a cardioselective beta blocker such as atenolol? Or should the clinical team consider adding an aldosterone antagonist such as spironolactone? Or should he be considered as a candidate for heart transplantation due to the recent nature of his illness? I'll give you 10 seconds to choose the best option or strategy among those four. I would settle for C. The clinical team should consider adding an aldosterone antagonist such as spironolactone. Now the signs and symptoms suggest that AHJ has a New York class 3 heart failure symptoms and the AHA stage C heart failure. This patient, in my opinion, should have an S inhibitor or an ARB if he can't tolerate an S inhibitor. The patient needs to have target dosing rather than a low dose regimen. So there should be up titration to doses that can be tolerated by the patient instead of keeping them too low. Now, beta blocker therapy, in my opinion, is indicated, but there's a caveat. It should be restricted to 3 choices which are backed by evidence-based medicine, and those include metoprolol succinate, carvedilol, or bisoprolol, not atenolol as we've been told in choice B. So B is out. Then selected patients such as those who have experienced an MI are candidates for aldosterone antagonists in the New York Heart Association class 3 disease. So that would be a good choice for him, and that explains why I would be biased towards alternative C. Let's move to the next question. It reads, which of the mechanisms of action listed below applies to Mipomersen, which is marketed as Kainamro? Is it true that it inhibits the HMG coenzyme A reductase, or does it bind to the ApoB100, or does it bind to bile acids, or does it bind to PCSK9? I'll give you 10 seconds to choose the correct mechanism of action. In my opinion, B is the correct answer. Now, this drug happens to be an antisense oligonucleotide targeted to human mRNA for ApoB100, the principal apolipoprotein of LDL cholesterol, and its metabolic precursor, which happens to be VLDL. It is complementary to the coding region of the mRNA for ApoB100, and it binds by Watson and Crick pairing. Now, the hybridization of Mipomersen to the cognate mRNA results in RNase-mediated degradation of the cognate mRNA, thus inhibiting the translation of ApoB100 protein. It is administered once weekly subcutaneously as an adjunct to lipid-lowering medications and to diet to reduce LDL cholesterol. It also reduces apolipoprotein and total cholesterol, and also even the non-high density lipoprotein cholesterol in patients with homozygous familial hypercholesterolemia. So it has a complex mechanism of action. I would suggest you read further on that if I was not very clear. Let's move to the next question. CGM is a 43-year-old white man who recently had an NSTEMI. He's currently taking aspirin and ticagrelor prophylactically. He presents to hospital with a lower limb DVT. As you manage his condition, what would be the ideal or recommended INR range for this gentleman CGM? Would it be 2 to 2.5? Would it be 1 to 1.5? Would it be 1.5 to 2? Or would it be 2.5 to 3? I'll give you 10 seconds to choose the correct answer. So I would choose 2 to 2.5. Now, historically in healthcare, we make an INR goal of 2 to 3. Now, recently the UA, the Unstable Angina Stroke NSTEMI Focused Update, published in Circulation and a class B 2B recommendation stating that targeting anticoagulation therapy to a lower INR range of 2 to 2.5 might be reasonable in patients with unstable angina or NSTEMI being managed with aspirin alongside a P2Y12 inhibitor. That makes me biased towards the 2 to 2.5 range. Let's move to the next question. Now, according to the outcomes of the ALLHAT trial, which antihypertensive below isn't preferred as first-line therapeutic option in patients with hypertension with no compelling contraindications? So is it lisinopril, doxazosin, amlodipine, or chlorthalidone? I'll give you 10 seconds to choose the correct answer. So doxazosin it is. Now, in the ALLHAT, which is A for antihypertensive, in full it's antihypertensive and lipid-lowering treatment to prevent heart attack trial, doxazosin arm was stopped early, secondary to an increased risk of stroke, heart failure, and combined cardiovascular events. It was also not superior to chlorthalidone in overall blood pressure lowering ability. It didn't prove very useful. It caused more harm than good. So that makes me biased towards answer B. Let's move to the next question. It reads that BCC, a 56-year-old black man, presents to the Aga Khan University Hospital cardiac clinic for evaluation of dyslipidemia. His past medical history is significant of peripheral artery disease, hypertension, COPD, and he has no significant family history. His social history includes the fact that he does not smoke, neither does he take any alcohol, and he says overall he's doing about as good as you could expect. That statement leaves a lot, leaves you wondering. His pertinent labs include a fasting lipid panel that showed the following: total cholesterol of 273, HDL of 23, LDL of 213, total TG of 183. So my question to you is, which pharmacologic option below would be the most appropriate for maximizing LD cholesterol lowering in BCC's case? Is it fluvastatin, rosuvastatin, cholestyramine, or niacin? I'll give you 10 seconds to choose the correct option. Personally, I would settle for rosuvastatin. Now, this patient has unknown atherosclerotic cardiovascular disease due to his peripheral arterial disease, which is considered to be a CHD risk equivalent by most clinicians. And as such, he is in need for a more than 50% LDL reduction. And of the options that are listed there, rosuvastatin would be the most potent option to maximize his LDL lowering, which should be lowered by between 50 and 60% in my opinion. Now, when you look at fluvastatin there in alternative A, the best it can lower LDL is by 35 to 40 as quoted by literature. Then cholestyramine is even worse. It lowers it by 15 to 30%. Niacin is even the worst of them all because it lowers by 5 to 25%. Now, those are less potent and they would not be the best initial choices, so I would end up settling for rosuvastatin instead of the other two. Let's move to the next question, please. Your cardiac team is considering initiating enalapril in a 59-year-old white male patient who suffers from type 2 diabetes mellitus and hypertension. Apart from his blood pressure, which other parameters should be evaluated and monitored prior to and during enalapril use? Is it heart rate, metabolic panel, also called CHEM7, liver function test, or hyperuricemia? I'll give you 10 seconds to choose the correct answer. So basic metabolic panel, CHEM7 it would be. Now, enalapril is an ACE inhibitor and it can cause hyperkalemia via decreasing angiotensin II activity, and that indirectly leads to less aldosterone activity. Now, it can also lead to an elevation in serum creatinine via a mechanism of decreasing the glomerular filtration pressure. So monitoring, baseline, and follow-up chemistry and metabolic panel would be the most appropriate, since the serum creatinine and potassium are included in the metabolic panel. Now, patients with underlying or non-bilateral renal artery stenosis are at an increased risk for developing acute renal failure with S inhibitors and with ARB use due to the dilation of efferent renal arteriole, and that can significantly reduce the GFR when stenosis is present. Now, the other choices, heart rate, liver function tests, and hyperuricemia, do not generally concern S inhibitors, but they should be considered with other classes such as the non-dihydropyridine calcium channel blockers, where heart rate and liver function tests should be monitored closely, or with beta blockers or calcium channels, or even the direct acting arteriodilatory drugs where heart rate becomes an issue, or with the thiazide diuretics where hyperuricemia may be a headache. So all those make B the best answer in our case. So, ladies and gentlemen, it's been my pleasure presenting these MCQs of our 30th part of the series. Thank you for sacrificing your time to watch and to view this video. Now, if this video benefited you in any way, I would like to urge you to remember to give it a thumbs up and to like it. And if you haven't yet done so, I would like to prevail upon you to subscribe to my YouTube channel. I would like to promise you from the bottom of my heart that the best is yet to come. I sincerely thank you for viewing and for listening, and I hope to interact with you in part 31 of our pharmacotherapy MCQ series. So thank you for always being there for me.